Hello to all viewers who are watching this. Basically, we have wasted 13 minutes and 13 or 14 minutes. We have delayed for now. Extremely sorry for that since we were facing some crisis and we have to guide our fellow panel members how to use this. So please pardon us for the delay and enjoy today's CME. So without wasting any more time, let's just start.
Good evening, everybody. Starting from day one, today is our 19th online CME. Sir, it's a great way from 1st to 19th. How do you feel, Kalyani, sir? Good evening.
Definitely, it is achievement of all of us, of course,
Right,
and
sir.
gift of COVID-19.
Right, sir. So every negative situation had a lot of positives, and we homeopaths of NIH, the alumnus of NIH, we always take positives out of negatives. So today, the 19th CME online will be having uh, a great panel and very interesting topic to discuss with. First of all, let me invite and request Dr. Swapan Pal, who is the lecturer, Department of Materia Medica, National Institute of Homeopathy. He has been a PG and UG alumnus of National Institute of Homeopathy to be the inaugurator and introduce the panel to all our live audience. I'll request backstage editor to bring on Dr. Swapan. Over to you, Dr. Swapan.
Thank you, Dr. Mukherjee. Good evening to all. Thanks to organizing secretary, the president of National Institute of Homeopathy Alumni Association for giving me the opportunity to address this August gathering in front of you on this platform. Regarding today's CME, we have two eminent speakers today, Dr. Monoj Behra and Dr. Riyom Taipodia. Both of them belongs to National Institute of Homeopathy, and they are very much close to me. I know them very personally. Dr. Monoj Behra is a voracious reader from his student life, and he had been to that very good in his speech in many times in different occasions. He is now the principal and the professor, Department of Surgery in Arihant Homeopathic Medical College and Research Institute in Gandhinagar. He will be enlightening us with the topic Anonymous Signs in Medical Science. And second speaker for today's CME, Dr. Riyom Taipodia. He is Vice President, the Arunachal Pradesh Homeopathic Council and Nodal Officer of Ayush, Government of Arunachal Pradesh. He will be enlightening us with recurrent urinary tract infections in post-menopausal women. So we hope that we'll be very much enlightened and will be very much rich in the information given by both the speakers today, and we are looking forward to them to have this great or vast knowledge about these topics. Regarding our CME, we have passed 18th CME. Now today is 19th CME. We have walked a long way, and we hope that we have some more many long path to go with this seminar, with this webinar. And this successful of this webinar or this CME is happening just because of your participation. And we hope that in future we are also expecting your full cooperation, full participation to this seminar to make the this seminar or CME very successful one. And every month the CMA we are getting much knowledge from the eminent speakers on this platform, and we are expecting some more eminent speaker in future also, and we'll learn many things from them. And today we are I am welcoming Dr. Manoj Behra and Dr. Riyom Taipodia on this platform to share their views on these two topics and enlightening us with their vast knowledge. Thank you all. And I'm just closing here, and the microphone is hand over to Dr. Bidyut Mukherjee.
Swapan, you have to introduce the moderator too. You forgot.
Okay, yeah. Sorry, I forgot. Today's moderator, Dr. Pralay Sharma sir. He is our Deputy Medical Superintendent in National Institute of Homeopathy. He has a vast clinical experience and vast clinical knowledge. We have also learned many things from him during my student life at NIH. And today we are expecting some more knowledge from him in between this discussion given by Dr. Manoj Behra and Dr. Riyom Taipodia, and we are expecting and we are hoping that we'll get a lot many things from Dr. Pralay Sharma because he has a very vast clinical experience, very vast clinical knowledge in his field. So thank you all for patience hearing.
Thank you, Dr. Swapan. Uh, and with permission of Kalyani sir, let's bring all the speakers and moderators on the screen. And I'll request Dr. Pralay, the moderator, to start the CME session today with the first speaker. Over to you, Dr. Pralay Sharma.
Thank you so much. And I've been here in this platform in the backstage for around half an hour, and everything been settled down. And we are around 13 to 14 minutes late today to begin with this webinar. First of all, with continuation of the speech of Dr. Swapan Paul, I would like to congratulate and I would like to convey my thanks, heartfelt thanks to the organizer, Dr. Mukherjee, Dr. Bidu Mukherjee, and Dr. Kalyani sir. I also wish to convey my heartfelt gratitude to the viewer who are watching this virtual platform in this virtual platform right now, and who will be watching this webinar, this seminar in future. We have with us today a very eminent speaker, Dr. Manoj Behra, and also Dr. Riyom Taipodia. And on behalf of this Alumni Association, I welcome both of them, and I believe that their speech will enlighten us with a huge knowledge regarding the topic to be discussed right now. And to begin with, I request Dr. Manoj Behra. He is a professor and principal of Arihant Homeopathy Medical College and Research Institute, Gandhinagar, to introduce himself and to begin with his lectures today for the viewer. Thank you so much.
Thank you so much, Pralada. Good evening, one and all. And it is indeed my great pleasure and honor to be a part of this August gathering, where I learned all my basics. And today I am delivering a lecture before my teacher, my seniors, my friends, and all my colleagues. It is indeed a great moment for me as well. To start with, let me first thank Dr. Bidyut Mukherjee, our beloved Bidyut, who has been very instrumental in getting me into this CME. When I got his call, let me tell you one thing. I was suffering from COVID-19, and he told me, "Okay, you do one thing. You get well soon. Then we'll give you a chance to speak." And today is the day I'm going to speak something. See. I must thank Swapan for such wonderful introduction, and I must thank one of my beloved senior, Dr. Pralay, for such kind words. In fact, it was a great time in NIH when we were studying, and Bidyut, Pralada, they were all like guiding forces for all of us, and we can never forget that. Let us keep this spirit on, and before I start, let me just give you a small introduction what I actually intended to do. See, when I was going through or I was watching the videos of previous CMEs, all my friends or my colleagues, all my teachers, they were trying to speak something regarding about their clinical experience. We all have clinical experiences. That's why I thought of doing it a little bit different. I thought of talking about something which we all have learned, we all are practicing, and but I feel we need to brush that up and we need to just polish ourselves by just knowing all those things again and again, because as as doctors we always practice, we are never the masters. We always being be students, we can never be the masters for our subject. That's why we say we practice, we keep on learning every day. So uh, uh, I would request Arka to just. So what I have tried to do, I have just uh, prepared some slides that will talk about the clinical science that we use in our daily practice, in our teachings, and we need to know them and need to understand so that we will be able to diagnose our patient properly and so that we can plan our treatment accordingly. So I'll request Arka to just show my slides or my presentation. Arka, can you hear me?
Yes, just open your slides, sir. Just click on the PPT, sir.
So I'll click on the PPT.
Yes, sir.
So for that I have to like minimize
Minimize
the
the,
this na.
yes, sir. Yes, sir.
Okay,
Minimize
okay.
this thing. And now turn on the full screen button. Yes,
Is
sir.
it okay
Just open.
now? Okay.
Yes, sir.
So dear friends, colleagues, seniors, and my teachers, I am going to present on eponymous signs in medical science. Now, this eponymous sign means, let me tell you the meaning of it. Eponymous means when somebody gives the name to any discovery. So, I will be talking about those signs that are being named after some scientist, some doctors, or some researcher. So we'll be talking about those signs. See, if you think of medical science, there are almost 250 or more than that clinical science. We study or we teach our students. But specially, I have thought of talking about those signs that are given after some stalwart, some scientist or some doctor's name. So let us begin with Aaron's sign. As the slide suggests, it was suggested by Charles Aaron, and you will find this sign in conditions like appendicitis. What this sign suggests? A sensation of pain or distress in the epigastric or peak cordial region when you apply pressure at the McBonus point. Now, when you are applying pressure at the McBonus point, you'll feel a sensation of pain or distress in the epigastric region. That suggests a disease called appendicitis. Now, let us move on to the next sign. I'll try to like just cover all those signs, not 253 signs. I have taken only 30 to 40 signs to be discussed today. The next one is Addison sign. It was suggested by Alfred Washington Addison. This sign suggests thoracic outlet syndrome. See, the idea of talking about those signs is that if you can diagnose or if you can reach to a substantial diagnosis just by doing some clinical examination, or if you for example, when the patient enters in your chamber, your observation, your diagnosis starts there and then. Suppose you see a patient with short height, idiotic look, unusual hair growth, oily face, round face. You think of a disease called Cushing's or Moon's faces, seen in Cushing syndrome. When you see a patient with adenoid faces, or when you see a patient with staring look, you think of Stellwag sign. So these signs or these facial expression, or maybe the attitude of the patient, at times the mannerism, the behavioral pattern of the patient always guides us to certain kind of disease states. So likewise, Addison sign. Addison sign was suggested by Alfred Washington Addison. It suggests thoracic outlet syndrome. Now see, when the clinician asks the patient, examines the patient with an extended neck to the affected side, asks the patient to turn the face to the affected side, and you see or feel the radial pulse. If you find the pulsation has gone down, or there is reduction or decrease in the pulse rate, that suggests thoracic outlet syndrome. Or alternately, if you can auscultate the subclavian artery, there will be a bruit, a typical sound that is felt with the stethoscope. So you may have heard about uh, cervical rib. The other condition is cervical rib. When you ask the patient to turn to the affected side and with an extended neck, and you feel the radial artery pulsation, if that pulsation showing some decrease in rate, that suggests thoracic outlet syndrome. Allen's test. This was suggested by Edgar Van Nuys Allen. This suggests the arterial supply of the hand. Now see, so it was actually described by Allen in 1929, and while you are physically examining the patient to know the arterial blood flow to the hands, the test is done to determine that collateral circulation. The collateral circulation is present from the ulnar artery in case of thrombosis occurs to the radial artery. So arterial supply of the blood you have to find out by finding out the circulation, presence of circulation in the ulnar artery if there is a thrombosis condition in the radial artery. So this was described in 1929 by Allen. So this test is known as Allen's test. Next comes Alexander's law. This is actually described by Gustav Alexander. I have taken the photographs with a lot of difficulty because the photographs were not easily found in Google as well. This is seen in vestibular lesions. Now, the state of amplitude of the jerk nystagmus is largest in gazing the direction of any fast component. This was suggested by Alexander. So this rule is called Alexander's law, and this is seen in vestibular lesions. The next is Apley-Grind test. It was suggested by Alan Graham Apley. This is seen in meniscal lesions. Asked how you can elicit this test or how you can do this test, ask the patient to lie down in prone position. The knee is flexed to 90 degrees and the leg is rotated from side to side. Ask the patient to lie down on on prone position, and the knee is flexed to 90 degree and the leg is rotated. As you can see in the top of this slide, and while you are rotating the leg from side to side, there is some compression force applied. A forceful response signifies the turn of degenerate meniscus. The turn of degenerated meniscus. This test is done to find out the meniscal lesions. Next is balance sign. It was suggested by Charles Alfred Balance. Now, you all have heard about the splenic rupture or any abdominal trauma or splenic trauma. Suppose you are traveling, you had a roadside accident, you fall on this side, the spleen can rupture, there can be tear in the capsule. That can lead to formation of an hematoma or oozing of the blood, gradual oozing of the blood that can lead to formation of an hematoma. Now, if you find any patient, now see, the peculiar thing is that the presence of persistent dullness, the presence of persistent dullness to percussion in the right, in the left upper quadrant, when you are percussing, if there is a persistent dullness in the left upper quadrant, that suggests positiveness of balance sign. Now, but this is very peculiar. We all know that any pathology just below the diaphragm, suppose a person has got a splenic rupture and you are finding a when you are palpating or when you are percussing, or when you are percussing you are finding a dullness, when you are palpating you can consistently feel a mass in the left upper quadrant, that suggests balance sign, and it can be because of abdominal or splenic trauma. But how the patient presents in the clinic or how the patient comes to our clinic, you may find very peculiar. You may find the patient comes to your clinic with holding his right shoulder blade, because any pathology in the peritoneum or below the diaphragm can produce sensitiveness or can produce pain in the corresponding shoulder blade or shoulder joint. So this is the peculiarity. Now comes Bloomberg sign. It was suggested by Jacob Mortis Bloomberg. This sign is seen in case of peritonitis, or if there is even in appendicitis, you are suspecting for some individual to have appendicitis. When you are applying pressure, the patient has got no expression or the patient feels nothing, but the patient feels pain or there may be change in his expression while you are lifting the pressure. While you are pressing on the abdomen, the patient has got no pain, but while you are lifting the pressure or when you are lifting the palpating fingers from that area, the patient may complain of pain or sensitiveness. This is mainly due to the inflamed peritonitis, or it can be seen in appendicitis as well. Boas Point. Now this was suggested by Ismar Isodor Boas in case of gastric ulcer. Now this is the area of tenderness to palpation. The area of tenderness to palpation to the left of the 12th thoracic vertebra, found in some patients with gastric ulcer. In some patients with gastric ulcer, you may find tenderness to the palpation to the left of 12th thoracic vertebra. These typical signs are very suggestive or clinically very helpful to reach to a substantial diagnosis while you are examining your patient. Likewise, you will find Boas sign. Boas sign was suggested by the same person, same individual. It is seen in case of acute cholecystitis. Now, what happens? There is increased sensitiveness. There is increased sensitiveness below the right scapula if any person has got acute cholecystitis. This is mainly due to the phrenic nerve irritation. This is due to mainly the phrenic nerve irritation, an area of tenderness to palpation, an area of, or the person may complain of increased or altered sensitiveness below the right scapula. This is seen in case of acute cholecystitis. Boas Point and Boas sign both are suggested by Ismar Isodor Boas. This is very important while we are examining any patient clinically. This is called Brody Trendelenburg's percussion test. This sign or this test was suggested by Sir Benjamin Collins Brody and Frederick Trendelenburg. So it is commonly known as Brody Trendelenburg's percussion test. It is seen in case of varicose vein. Now, what we are doing to determine the valvular competency or incompetency, sorry, to determine the valvular incompetency in superficial veins, a finger is placed at the lower distal part of the vein. You are placing a finger at the lower distal part of the vein that is being examined. The upper proximal part is then percussed and tapped. If the impulse is felt at the lower part while you are percussing the upper proximal part or tapping the upper proximal part, if the impulse is felt at the lower part, it indicates incompetency of that vein. That is seen in case of varicose vein. Let me again explain. To determine the incompetence of in superficial veins, a finger is placed at the lower distal part and the upper proximal part of that vein is tapped. If you feel that impulse, on the lower part, it indicates incompetence of that vein. It may be seen in case of varicose vein. Next comes Bidyut's sign. This sign was suggested by Pierre Constant Bidyut. It is seen in case of suppurative mastitis. Now suppose we are mixing pus with milk. You will find a different colored or different textured fluid. So likewise, to determine or to when you think or when you suspect an individual or lady is having mastitis, to differentiate between lymphangitis of the breast and the infections and the other infections often bacterial or especially the mastitis. Suppose you want to differentiate between the lymphangitis of the breast and the mastitis of the breast, you have to do this test, Bidyut's sign. In case of suspected mastitis, to differentiate the lymphangitis of the breast, brown, yellow or bloody traces when milk is mixed with pus. This indicates suppurative mastitis. Burgess test. It was suggested by Leo Berger to find out the peripheral artery diseases. What we do, we ask the patient to lie down. And if you can see in the picture, and we start elevating his leg, the suspected part maybe, or the suspected leg you are elevating. What happens after a certain point of time, that limb becomes pale or there is change of color. While you are elevating that limb, that change of color occurs at certain point. That point or that angle created by the elevated limb and the horizontal examination table is known as actually vascular angle or Burgess angle. So Burgess test is, while you are elevating the limb, there may be change of color. Just in which angle the change of color occurs, that suggests about peripheral artery disease. Now, if that change of color occurs below 30 degrees, suppose the individual is lying down, you are elevating his limb, and below 30 degree that change of color of that elevated limb occurs, that suggests the condition or the condition of that person is very severe. Now if it occurs in after elevation of the limb to 45 degree, it is a moderate stage. And if it occurs after elevating the limb to 60 degree or maybe 90 degree, that means he's little bit okay, or his condition is stable, or the condition is just started. But if that occurs below 30 degree, you can think of the severity of the case. Now, if you ask me, I can discuss few more things related to the in case of any arterial disease, we first do this to elicit or to know the condition of the vessels or the arteries, especially, or veins. So this is Burgess test. what we do, we elevate the limb and to see the angle created by the elevated limb and the horizontal examination table. That angle or that test suggests us the condition of our vessels or arteries. Caput medusa. It was named after Medusa or Medusa. This suggests portal hypertension. Now, see, this is an inspectory finding. The moment you are examining any patient for abdominal regions or abdominal pain or anything related to abdominal examination, you may find formation of cluster of veins around the umbilicus. The veins, like you can see the hair of Medusa. This is formation of cluster or so if you find any individual having formation of cluster veins around umbilicus, you can think of caput medusa, and that is seen in case of portal hypertension. Next is Cardarellis sign. This was suggested by Antonio Cardarelli. This is done to know the aortic arch dilatation or aneurysm or even mediastinal tumor. Now, if you do an abnormal palpation or if you find any abnormal pulsation of the trachea, that may be found in patients with a dilatation or aneurysm of the aortic arch. If you palpate while palpating, if you find any abnormal pulsation of the trachea in an individual, you may suspect, or that can be due to dilatation or aneurysm of aorta or aortic arch. This is actually felt by the physician by pressing thyroid cartilage. This is felt by the patient by pressing thyroid cartilage and displacing it to the left. This sign was suggested by Antonio Cardarelli. So this is known as Cardarellis sign. This gives us an idea about aortic arch dilatation or aneurysm or even mediastinal tumor. Next is Carbonate sign. This was suggested by John Barton Carnett. We elicit this sign to find out abdominal mass or pain. Now, this is a clinical examination of acute abdominal pain. This is a clinical examination of acute abdominal pain which remains unchanged or increases when the muscles of the abdomen are tensed. When the muscles of the abdomen are tensed in acute abdominal conditions, it may increase or it may remain unchanged. It is the clinical examination in which acute abdominal pain remains unchanged or the pain may increase if you tense the abdominal muscles. Next is Charcot's sign or Charcot's triad. Now, this is almost 95%. This was suggested by Jean Martin Charcot. This is seen usually in case of ascending cholangitis. Why it is called Charcot's triad? Three clinical signs or three clinical features are very much marked. Almost fever for almost 95% cases, right upper quadrant pain 90% cases, and jaundice almost 80% of cases. This is seen in case of ascending cholangitis. Next is Codmans Triangle. Codmans Triangle. This was suggested by Ernest Codman. This we do in case of when we suspect osteosarcoma or Ewing's sarcoma, or it is a radiographic appearance of the rim of new subperiosteal bone which forms when a lesion such as a tumor lifts the periosteum away from the bone. Now, three main causes of this Codmans Triangle are osteosarcoma, Ewing sarcoma, and subperiosteal abscess. So, when this is a radiographic appearance of the rim of new subperiosteal bone, and this is seen in case of three conditions: osteosarcoma, Ewing sarcoma, or subperiosteal abscess. Next is Cullen's sign, or you can say Cullen sign. Now this is very peculiar. Now this is also a sign which can be seen while we are inspecting, or this is can be an inspectory signing. The same condition, you are going to examine the abdomen, you have exposed the parts. Now if you find there is uh, especially onion skin appearance around the umbilicus, and this is seen in case of acute hemorrhagic peritonitis, or even in case of intra-abdominal hemorrhage, or even ectopic pregnancy. If you go through like clinical books on surgery, you will find Cullen sign and Grace Turner sign both are usually seen in case of acute hemorrhagic pancreatitis. So if you find there is onion skin appearance around the umbilicus, or the pinkish discoloration around the umbilicus, you may suspect this acute hemorrhagic pancreatitis. That is seen in Cullen sign. This was suggested by Thomas S. Cullen. Next is Dance sign. This sign was suggested by Jean-Baptiste Hippolyte Dance. It is seen in case of ileocecal intersusception. Now, on investigation of the right lower quadrant of the abdomen for retraction, which can be an indication of intersusception. Intersusception, we all know when the invagination occurs. So, on investigation on right lower quadrant of the abdomen for retraction, you suspect the abdomen may be retracted. So while you are investing on that, the abdomen may show retraction of the right iliac fossa. So in case of intersusception or ileocecal intersusception, when you examine the right lower quadrant, it may show retraction of the right iliac fossa. This is called Dance sign. Next is Dunphy sign. This sign was suggested by John Engelbert Dunphy. It is seen in case of appendicitis. Now it suggests, this sign suggests there is increased intra-abdominal pain when you are coughing. While you are coughing, the intra-abdominal or the abdominal pain may increase. That is suggestive of appendicitis. I am purposefully actually trying to just finish it up because there are so many signs. We all may forget everything. So just trying to move a little bit faster. If anybody has got any like query or anything you want to discuss, you can definitely talk to me. But I'm thinking of finishing at least 30 to 35 slides at least. So the next slide is, or the next sign is called Fothergill's sign. It was suggested by John Fothergill. It is seen in case of rectus sheath hematoma. Anterior abdominal mass, any anterior abdominal mass which does not cross the midline and is still palpable when abdominal muscles are tensed. Please mark my words, anterior abdominal mass which does not cross the midline is still palpable when abdominal wall muscles are tensed. This is seen in case of rectus sheath hematoma, and this sign is called Fothergill's sign. Now moving on further, the next is Goodsall's rule. This was suggested by David Henry Goodsall in case of anal fistula. This is very peculiar and very interesting sign as well. Now, while examining a patient for fistula or for perianal or anorectal abscess, we draw an imaginary line, transverse imaginary line. If you will find the fistula opening is anterior to this transverse line, the track will be radial. You can see this at the top of the slide. The track will be radial. But if it is present posteriorly to this transverse line, there will be like curved, there will be curved track, and it will be at the midpoint of the posterior line, the curved line. And if so, this is what is suggested by Goodsall's rule, and it is seen in case you must have heard about horseshoe fistula. So how these two openings are behaving or are present in the perineum or in the anal region, this suggests if it is the opening is anterior to the transverse line, imaginary transverse line, it will be radial in nature. If it is present in the posterior part, then it will be curved. I have already told you about this sign, Gray-Turner's sign. This was given by George Gray Turner. It is seen in retroperitoneal hemorrhage or the same condition in case of acute hemorrhagic pancreatitis. The skin discoloration or blushing in the left flank. Now in Cullen's sign, you found the discoloration was present in the around the umbilicus. And in case of Gray-Turner sign, this discoloration is present in the flank or especially left of the flank. This is seen in acute hemorrhagic pancreatitis or retroperitoneal hemorrhage. Next is Homan's sign. This was suggested by John Homans. It is seen in deep venous thrombosis. Now, passive forceful dorsiflexion of the foot with extended knee will cause tenderness in the calf muscle. Passive forceful dorsiflexion of the foot with extended knee will cause pain or tenderness in the calf muscle. This is seen in case of deep venous thrombosis. This is called Homan's sign. Next is Hausif-Romberg sign. This was suggested by two gentlemen, John Hausif and Mortis Henrik Romberg. This is seen in case of obturator hernia. Now, what it suggests, this sign says painful inner thigh on internal rotation of the hip. Painful inner thigh on internal rotation of the hip, seen in case of obturator hernia. But this sign should not be confused with neurological Romberg's sign, which is seen in sensory ataxia. There can be neurological Romberg sign that is seen in case of sensory ataxia. This sign should not be confused. The next sign is Kahr's sign. It was suggested by Hans Kahr in case of ruptured spleen. Friends, I have already discussed this. When there is acute pain, at the tip of corresponding shoulder joint, you can suspect due to presence of blood or due to presence of any irritant just below these areas in peritoneal cavity, especially in splenic rupture. When the spleen ruptures, if there is hematoma or there is rupture of blood due to the trauma, that can lead to formation of an hematoma. And you have seen balance sign. Previously I discussed Kahr sign is if any pathology or any hematoma, any fluid, any irritant in these areas, that will cause pain in the corresponding shoulder joint. So I told you the patient usually can come by in this position or in this fashion. He may be holding his shoulder and the pathology is somewhere else. Okay, the next is Kocher's sign. It was suggested by Emil Theodor Kocher. It is seen in case of hyperthyroidism or Bestow's disease. Now, you all have heard about Stelvag sign, Dalrymple sign, then Mobius sign. These are all clinical, the eye signs of uh, like your thyroiditis or toxic goiter. So these signs, especially this Choochs sign, is linked to the eyelid disease. This Choochs sign is linked to the eyelid diseases, especially seen in case of hyperthyroidism or Bestow's disease. Occurs convulsive retraction of the eyelid. Occurs the convulsive retraction of the eyelids on fixation on any upward movement. Suppose you want to just fix your eyes, a person suffers from hyperthyroidism or maybe Besdow's disease, or if you ask her or him to fix his eyelids like this, there may be some convulsive retraction of the eyelid. This is called Choochs sign. The next one is very easy and very commonly discussed or examined. It is called McBonus Point. It was given by Charles McBurney. The significance of this point is in case of appendicitis. And what it is 1/3 of the distance from anterior superior iliac spine to the umbilicus. 1/3 of the distance from anterior superior iliac spine to the umbilicus is called McBonus point. The significance is in appendicitis. Next is Murphy's sign. See, there are two things, Murphy's sign and Murphy's triad. We should not get confused. Murphy's triad is seen in case of appendicitis, acute appendicitis, where all those clinical features are approaching or are appearing in a particular fashion, like pain, vomiting, pain, fever, vomiting. So this is called Murphy's syndrome or Murphy's triad. But Murphy's sign is seen in case of cholecystitis. Now, while you are palpating the subcostal area, or while you are palpating these areas, when at the height of deep inspiration, if you apply pressure at the right subcostal area, there may be a catch in the breath. Catch in the breath means it is not like a cricket ball catch. It is the patient may show some kind of expression, that grimace, that sense of pain or distress when you apply pressure in these areas. This is seen due to the inflamed gallbladder, which when it comes closer to the palpating finger. Suppose, ask the patient to take deep breath. At the height of deep inspiration, while you are applying pressure at the subcostal areas, right-sided, the patient may show some kind of facial expression or may complain of pain, or there may be some tenderness. This is mainly due to when the inflamed gallbladder moves to your palpating finger. So this is called Murphy's sign, seen in cholecystitis. Next is Pemberton sign. This was suggested by Hugh Pemberton. It is seen in retrosternal mass with superior vena cava syndrome. What it suggests, this sign is used to evaluate venous obstruction in patients with this sign is used to elicit or evaluate venous obstruction in patients. Now, the sign is positive when bilateral arm elevation causes facial plethora. The sign is positive when bilateral elevation causes facial plethora. It has been attributed to cork effect, resulting from thyroid obstructing the thoracic inlet. It has been attributed to thyroid obstructing the thoracic inlet, thereby increasing the pressure on the venous system. So when you elevate, the bilateral elevation causes facial plethora. The face, you can see the picture, reddish, or it is full of blood. The patient shows as if the face is full of blood. This is seen in case of Pemberton's sign. Phalanx Maneuver. It was suggested by George S. Fallon. It is seen in case of carpal tunnel syndrome. Now, it is positive when flexing the wrist, to 90 degree for 1 minute, and you elicit the symptoms in the medial nerve distribution. It is positive when flexing the wrist to 90 degree for more than 1 minute and elicit the symptoms in medial nerve distribution. This is called Phalanx Maneuver, seen in case of carpal tunnel syndrome. We are left with very few signs. Rigler's sign. Rigler's sign was suggested by Leo George Rigler. It is seen in pneumoperitoneum, or it is also known as bas relief or double wall sign. This sign is also known as double wall sign. It denotes the presence of air along the luminal or peritoneal aspect of the bowel wall on supine abdominal radiographs. Rigler's sign is, it denotes presence of air in the luminar or peritoneal aspects of the bowel wall on supine abdominal radiographs. This suggests pneumoperitoneum. Next is Rinne's test. This is a very common test that is done. This is a very common test that is done in I'm not able. Rinne's test is primary. Okay, I've lost the slide. Maybe I'm not able to go back. Rinne's test is primarily used to know the loss of hearing in 1 ear. It compares the perception of sound. It compares the perception of sound transmitted by air conduction to those transmitted by bone conduction. This is Rinne's test. We usually do like in ENT OPDs. You will very often found somebody is doing that test. The next is Rosenstein sign. It was suggested by Paul Rosenstein. It is seen in case of appendicitis. It is also known as Sitkovsky sign. When there is tenderness in the right lower quadrant that increases when patient moves from supine position to recumbent posture on the left side. This is called Rosenstein sign. That abdominal pain or when the tenderness in the right lower quadrant increased when the patient moves from supine position to the recumbent posture on the left side. I think the last sign, is Robsing sign. This is suggested by Niels Thorkild Robsing. It is also a very significant sign to diagnose appendicitis. It is also known as referred rebound tenderness. Now see, while examining the abdomen, when you are applying pressure as shown in the picture at the top, while you are applying pressure at the left iliac fossa, the patient may complain or the patient may feel tenderness or pain in the right iliac fossa. This is mainly due to when that inflamed appendix is moving, or the bowel wall that is moving towards the palpating fingers, or the you can say the gases or the air is moving. So that creates that pain. This is known as Robsing sign. It is very significant to diagnose appendicitis, or especially it is also known as referred rebound tenderness. So I think this is all I have right now. Hello? Hello?
Yes, sir.
I think this is all I have right now. So,
Okay, fine.
yeah, thank you so much. Thank you everybody for patience hearing. I just purposefully ended the show because there are so many signs that will almost 253 signs are there. It may become boring at times because all are having some special characters or some special features, not difficult to means not easy to remember and to understand. But my purpose was just to brush your memory. That is it.
Uh, Thank you, Kalyani sir. Let's bring on Pralay on the screen to give his views, or if you want to give his views at the end. Over to you, Pralay.
Thank you. Thank you so much. I wish to put my view right now. And it was, in fact, a wonderful presentation by Dr. Monoj Behra, as well as he has been very good in his speech today in this webinar. And I believe that he is a professor of surgery, and whatever sign have been discussed in relation to eponymous sign, and that was mostly cover that has mostly has covered the surgical part. And as we all know that, as he also said, that in our webinar, in our seminar, we almost always talk about the subject homeopathy, its approach, and the clinical side is always been discussed in different angle. But today, Dr. Monoj Behra has brought this angle. Dr. Monoj Behra has brought a new arena of discussion. That is by talking about the sign. And we all know that to evaluate, to put example of the sign, that there are some clinician who has uh, done his sacrifice towards understanding by his observational power day after days, and has made a sign for the medical science. As a few days back, on 26th of January, we have recalled our martyr, the freedom fighter who had sacrificed the whole of the life for the freedom, for the country. And there are many persons who has sacrificed their life for the cause of the medical science. In fact, this was a great tribute by Dr. Monoj Behra, where we all has listened that the contributor of the medical science, into a contributor in the medical science in this platform today. He has described about many conditions, many signs into his deliberation, and these was in fact from mostly from the surgical part. But as we all know that in other aspect of the medical education, we do have endless, ceaseless number of the sign which we may not count into our account. And the example cited by Dr. Monoj Behra was excellent one, as we always do our endeavor to understand. Like, I am just putting one example what he has discussed, that when we try to understand the uh, arterial disease, the peripheral arterial disease, we always put basically the legs up to understand the lower extremity arterial diseases. And very nicely he has described that what is the angle, that if it is 30-degree angle, there is a color change in the leg. That talks about the severity of the arterial disease. If it is a 45-degree angle, then that speaks about this is mild to that speaks about the moderate degree of arterial occlusion. And if it is in 90-degree, that talks about the mild degree of the arterial occlusion. So this is how he has described, and we all know that this is a Berger test, but we forget the name of the test and the person who was concerned, who has contributed, who has given us this sign to understand, that we possibly forget to remember. And it was a great tribute. And he has also talked about the caput medusa, as we are very tempted and excited to discuss about that caput medusa, because whenever a patient of cirrhosis of liver comes to us, we always look towards the umbilicus. And of course, when you look towards the abdomen, always our eye focus goes towards the umbilicus. And it is true that if you get a venous dilatation around the umbilicus, and if there is a flow of blood from center to periphery, we understand this is a caput medusa. and this is one of the sign of your portal hypertension. As like that, you all know that in portal hypertension we have some episode of hematemesis as well as the bleeding per rectum. And this is being the scenario that he has nicely described about the caput medusa. And very often we do forget this was named by someone's contribution. Someone was there to make this sign possible in the medical science. And Dr. Monoj Behra has said about the Coolen sign, very interesting one. And we always know that when you get a acute abdomen with the pain, and we always look towards the abdomen, and we always look towards the periumbilical region. If there is a discoloration, as is stated, basically this is a blue discoloration that indicates a rupture of the viscera inside the abdomen, and it is particularly found in case of acute hemorrhagic pancreatitis. This is also to note that in gross discoloration in acute pancreatitis, there is a gross discoloration around the loin too, which has been called as gray Turner's sign. So this is an addition to understand the acute hemorrhagic pancreatitis. And I would like to talk about some of the other enormous sign to discuss about, which has been left around because these are from the practice of medicine, apart from the surgical condition. These are like very excited to talk about the Kussmaul sign. I do not know. There was possibly there were someone named as Kussmaul, and he might have contributed the excellent sign by his keen observation into the medical science. That you all know that when we take inspiration, our right atrium sucks the blood into the right atrium. That sucks the blood. That is the reason. Though when you look towards the jugular vein, the venous pressures falls down. This is a normal one. When we take the inspiration, the venous pressure falls down. As a result, there is less visibility of the jugular vein. But on the contrary, if somebody have a constrictive pericarditis or has a pericardial effusion, this cardiac tamponade, then what will happen? That when we take a deep inspiration, the venous blood gets obstruction. The right atrium cannot suck the blood well as it was, and that is the reason when he takes a deep inspiration, there is a congestion of the blood in the vein, which is visible over the neck, and there is raised jugular venous pressure, and we can find that the vein has been engorged more in inspiration. This is basically a Kussmaul sign, and this is excellent sign what we get in our medical science to understand the constrictive pericarditis as well as pericardial effusion in the bedside. Rest of the job is your percussion, that you have to focus and you have to understand whether the person is suffering from pericarditis or constrictive pericarditis or from the pericardial effusion. He has talked about Singh sign. He has talked about many of the signs which are too much beneficial for our day-to-day practice as a clinician, that we have to evaluate the patient and we have to understand the disease diagnosis. Apart from the signs, if we recall that there are some diseases too which are named by some of the name of contributor in the medical science, some of the researcher, some of the great physician, by their observational power, they have contributed some of the diseases to be categorized in the medical science. Like we have plenty of the diseases which has been named by some of the great physician. I'll just recall one of the name is a Parkinson disease. it is a Dr. James Parkinson. His observation, his keen observation, has categorized the disease that there is a tremor, there is a marked faces, there is there is a rigidity in the extremities. By all these signs and symptoms, he has aggregated all this and has named the name of the disease as a Parkinson disease. As like we have a Huntington disease, we do have a Alzheimer disease, Alois Alzheimer. He introduced this, he has categorized this disease into the medical field, the Alzheimer disease. We do have a Crohn's disease, we do have a Tourette syndrome, and we do have a Hodgkin lymphoma, we do have a Bright disease, we do have a Addison disease, we have a uh, we have etc. We have a Hansen disease, like in leprosy. We call this a Hansen disease. Someone possibly some doctor named as Hansen has contributed this leprosy. And it was wonderful discussion. I would like to thank the viewer as well as Dr. Monoj Behra for bringing up a new dimension, for bringing up a new arena of discussion in this platform. And I believe that this discussion will be helpful to all of us, as well as it will be helpful to all the students who are watching this show and who will be watching this show. It will definitely come in use. I believe that whenever this platform will call him for a discussion, will invite him for a discussion, he will be readily available in this platform to discuss about it. To these few words, our next speaker is waiting for a long time, Dr. Riyom Taipodia. I do have a long time association with him. He has completed his undergraduate from our institution, and very recently again he joined as a postgraduate trainee in our institution. And in 2017 he has completed this course, and presently he is posted in Itanagar, and he is a nodal officer of the Ayush system. I have been in Arunachal Pradesh. I have seen his activity out there, and I believe that with his power of a great orator, he will speak well in front of this viewer, in front of this August viewer in this webinar today. With these few words, I request Dr. Riyom Taipodia to be on the stage and to deliver his speech. Thank you, Dr. Riyom Taipodia. Thank you so much.
Good evening, everyone. Respected Kalyani sir, Bidyut Mukherjee sir, whom we used to call Vidudda, respected Parlay Sharma sir, whom we used to call Parlay Da, Manoj Behra sir, Manoj Da, Swapan sir, my batchmate, not forgetting Arkha. Good evening. Thank you very much for giving this opportunity to be with you this evening, and it's my honor. They are just saying that madness, those people who are mad, they only create history. So people used to laugh at Edison. They consider him as a mad person, but because of his madness, we can see light today. Similarly, there was a madness inside Vidudda. That's why we are here today. And there is also a saying that invisible causes visible. Means whatever visible things you see today, it is only the result of invisible thing started inside the mind. For example, when in the invisibility, if people they think of robbing a bank, naturally one day or another day we can see it in visibility that they are robbing. So forming this alumni, it started inside Bidyut's mind in invisibility. So today it is invisible. We can see we are together. And this started in the year 2010 when NIH organized international seminar. So Bidyut was there. It was his idea. And then Sujitda was there. Somnath Mitra was there. I was there. If I have not mistaken, we have formed this alumni association and we took photographs together, and photograph is still with me. Thank you, Vidudha. Because of you only, many we all discuss. Because of Vidudha, we are in webinar, we are discussing, we are reunited. Thank you so much, Vidudha, for this. And well, my presentation is concerned. I'll make it short because time is very limited. And then my topic is a recurrent urinary tract infection in postmenopausal women and its homeopathic management. Actually, why I took this topic, it was because women, if you see today, wherever we go, even in NIH, UG or PG, girls are more. Capacity in the hostel also, it is made for boys more, but girls are coming more. And wherever you go, in job, in CBSE, everywhere girls are coming. Women means women are coming up. So they have taken the works that men are doing, and then everything is given by women only. But particularly, they reach in certain age where they have really some reason to be not part of you wherever. Suppose in some meeting, important meeting, or in a party, when woman suffers, when she has this urinary infection, urinary tract infection, when he has to get up frequently instead of enjoying the party and instead of giving time to the meeting, she used to search for washroom, where to go, how to go, whether it is near or not. So don't we feel that we must give some relief to this kind of important women who are part of us making decision, but because of her recurrent urinary infection, because of his frequent micturition, because of her urging, sorry, because of her urging for urination, she cannot concentrate on her meeting or party. So that I thought, and then each and every house, they have woman, they have mother, they have grandmother, those who might be suffering from this kind of infection, recurrent urinary infection. When woman is suffering, everyone suffers. That's why I thought during my research, during my dissertation, I must take this topic, and I did. And I have done it very nicely. I have done it. I have taken 30 cases. Out of that, 25 cases responded very well to homeopathic treatment, and 5 couldn't. So that I wanted to just show you in very short, uh, without taking time. So what is UTI? Instead of explaining it, I would like to show you in a video in very short what is recurrent UTI. So please be with me.
With cystitis, cyst refers to the bladder, and itis refers to inflammation. Therefore, cystitis describes an inflamed bladder, which is usually the result of a bacterial infection, but also can result from fungal infections, chemical irritants, foreign bodies like kidney stones, as well as trauma. Now, a urinary tract infection, or UTI, is any infection of the urinary tract, which includes the upper portion of the tract, the kidneys and the ureters, and the lower portion of the tract, the bladder and the urethra. So, cystitis, when it's caused by an infection, is a type of lower UTI. Lower UTIs are almost always caused by an ascending infection, where bacteria typically move from the rectal area to the urethra and then migrate up the urethra and into the bladder. Having said that, on rare occasions, a descending infection can happen as well, where bacteria starts in the blood or lymph and then goes to the kidney and makes its way down to the bladder and urethra. Normally, urine's sterile, meaning bacteria doesn't live there. The composition of urine, which has a high urea concentration and a low pH, helps keep bacteria from setting up camp. Also, though, the unidirectional flow in the act of urinating also helps to keep bacteria from invading the urethra and bladder. Some bacteria, though, are better at surviving in and resisting these conditions and can stick to and colonize the bladder mucosa. E. coli accounts for the vast majority of UTIs. Also, though, other gram-negative bacteria that can infect the bladder include Klebsiella, Proteus, Enterobacter, and Citrobacter species. On the other hand, gram-positive bacteria can also cause problems, like Enterococcus species and Staphylococcus saprophyticus, which is actually the second most common cause overall after E. coli, and particularly affects young, sexually active women. That said, as far as risk factors go, sexual intercourse is a major risk factor, because bacteria can be introduced into the urethra, and this is sometimes even referred to as honeymoon cystitis. In general, women are at higher risk for cystitis than men, due to having a shorter urethra. And this is because bacteria, which are ascending up the urethra, don't have to travel as far. Also, in postmenopausal women, there's a decrease in estrogen levels, which causes the normal protective vaginal flora to be lost, increasing the risk of UTI. Other risk factors include presence of a Foley catheter in the urethra, which can introduce pathogens. Another risk factor is having diabetes mellitus, since people with diabetes tend to have hyperglycemia or high blood glucose. Normally, with an infection, neutrophils move out of the circulatory system toward the infection, called diapedesis, as well as carry out phagocytosis. But hyperglycemia inhibits these processes, making those neutrophils less effective at killing invaders. Also, infant boys with foreskin around their penis have a slightly higher risk of UTI compared to infant boys who've had a circumcision. A final important risk factor is impaired bladder emptying causing urinary stasis, which means urine tends to sit still, allowing bacteria the chance to adhere and colonize in the bladder.
Go for definition. You already know what is UTI. And then urine collection, how to collect it. These things also I don't need to tell because you all know. And then I don't think that I should go for epidemiology also. And then pathogenesis you already know that replaced by uropathogenic bacteria, and then it ascends and causes bacterial cystitis. All these things I don't think I need to tell you. And you already know the uropathogens, E. coli, Staphylococcus, Streptococcus, Klebsiella, all you know. Risk factors also, you know, it's all menopause and family history, sexual activities, use of spermicides, and the recent antimicrobial use, you already know. Clinical approach also, I don't think I need to tell you. And signs and symptoms, you all know that frequent urging for urination, hematuria, back pain, everything you know. And then I don't think it is, I need to tell you. If I go in detail again, it will take time. So better to be in a very short, to make it short. And diagnosis, though, you already know that the main thing that you need to do is a culture, urine culture. And then like I'll go in short. So prophylaxis, you already know, these are the things. Drink plenty of water, urinate frequently, clean your genital areas from back to front to back, all these things. And yeah, I may come back anytime, but today lack of time, I would like to go bit fast. These are some of the yeah, our homeopathic remedies for recurrent urinary tract infection. Yes, I would go for case that I have taken 30 female. That out of that 30 enrolled, 25 they have reported complete resolution of signs and symptoms, whereas 5 couldn't. And then frequently used medicines were given in this chart is nitric acid and medorinum, and this based on totality of symptoms, and then rest after that Valvaris, Netramure, like that. So just I want to present you one case of that. Like this is the details of the patient. It was in the 2015 7 Feb. Today it happened to be a 7 Feb, exactly 15, 16, 17, 18, 19, and today happened to be a 7th Feb. And these were the presenting symptoms. Burning while passing urine since 15 years. There was a recurrent attack of burning pain while passing urine, chilliness sometimes, fever, and the complaint started after tibutami done 70 years before that. And then she had treated with allopathic medicines and all. So past history is, as I already told, family history, mother had heart disease, and then personal history was addiction to pan and all these things. And then physical generals, uh, it is seen that these are the symptoms: appetite, desire, aversion, thirst, tongue, stool, urine, perspiration, sleep, dream. I'll give you in detail later. And these were the mental symptoms that I had noted in that particular woman. Fear of death, desire, solitude, irritability, forgetfulness, consolation ameliorates, sadness in the evening, all these things. And provisional diagnosis was, I won't go in detail, it was recurrent urinary tract infection, and ESR was increased, and there was pus and epithelial cells. And the final diagnosis was recurrent urinary tract infection. And these were the totality of symptoms: mental generals, physical generals, and particular. And in mental general, I have taken fear of death as one of the most important symptom, and then sadness in the evening. And these are the physical generals: desire for salty food, desire for lime, clay, aversion to meat, ravenous hunger. And particular symptoms are like burning pain during urination, burning pain after urination, offensive urination. And these were the totality of symptoms. But rest part is conversion. This is already converted symptoms to the rubrics. And then it was during our time, we used to do manual repertorization, but thank God and then thank you to this uh, computer or whatever. So, and I have fed all the symptoms, and then accordingly, you see that the nitric acid came in the first line. Then these are the medicines: calcarea, netramure, and all. And then finally, selection was made on consultation with Materia Medica. Selection was nitric acid. And you all know that in NIH, we used to give 50 millismol potency. So 0 by 1 and 0 by 2, 16 doses were given on alternate day. And and in the next follow-up, you can see, I think that the date was mistakenly, yeah, yes, it is correct, correct. Yeah, you see in the second visit, and all her burning pain during urination was reduced, and burning pain after urination also reduced, offensive urine also reduced. And then again the nitric acid 0 by 3 alternate day was given, and on third visit you can see that the burning pain during and after urination was completely absent and no offensive urine. Patient improved. So again 0 by 4 was given. And at the end part of the year 2015, all symptoms of UTI was completely not there. And then just patient was having common cold. So I gave Bryonia. So according to me, some people they feel that homeopathy doesn't work, but when homeopathy is prescribed according to the law of homeopathy, when totality of symptoms are being followed according to accordingly, these medicines worked marvelously, and out of the 30 cases, 25 cases, uh, their symptoms, sign and symptoms went off. So when there is no cure, when there is no relief after spending much money, after returning from many developed countries, when really these women they have this problem, it really a matter of concern. So when we could give relief to these women, postmenopausal women especially, so we too we feel that we are doing our part. Being homeopath, we are blessed. So my conclusion is that the homeopathic management is strictly based on the principle will surely bring result, and that I am doing here also. Actually, my job is not in the hospital. I am in the directorate office. All my works are not related to hospital. But after going through my PG from NIH, I realized when homeopathy is prescribed based on the totality of symptoms, if these 25 cases out of 30 can be cured, if we try, why why it is not possible? Definitely we can do. That's why after coming back from NIH, I have opened a clinic, and my clinic is only 6 months old, and I'm getting a good number of patients. Some of my friends are saying that there are no homeopathic patients are not in favor of paying higher charges. But my patients are coming, they are giving me money. It is me who is not receiving. And it is me who is directing them that if you wish to pay, you pay through digital. My accounts are given in the system. So they pay. So what I share with my friends are that they are also practicing homeopathy. I am also practicing homeopathy. Same thing is being practiced. Game is being played by both of us, but you play it in different way and I play in different way. So it depends how you play. So I am very much happy. That's why I thought I must do something in this field. I must do some research. I must do something new to prove that homeopathy works. That's why during my COVID period, I have appeared my PhD exam online, and suddenly I got selected. And then now I'm doing my PhD from Homeopathy University, Rajasthan. And then my topic is same, which I am showing you. And then all among our batch, my topic is the best topic for the research. So not doing the same thing, I'm taking the same postmenopausal woman, but doing it in different way. So I have made two groups, one in placebo, one in this medicine group. So that's why I have been, when I went back to NIH again improved me. Everything was given from NIH, and PG also given from NIH. I have been refined from NIH. NIH has given me many things. Because of NIH, I can think for higher studies. So I am very thankful to Bidyut. Because of his madness, we are united. I am sitting in the remotest part of India and communicating with you sitting in Delhi, Kolkata. So this is because of invisible things started in Bidyut's mind, which is visible. We all are enjoying. With this, I would like to conclude my um, online CME. Thank you very much, Bidyut. Thank you very much, Orkha. Thank you very much, Swapan. Thank you very much, Manojda. Thank you very much, Pralayda. Thank you, Kalyani sir. Thank you.
Thank you, Riyom. It's a very nice and crispy presentation. But relating to the foundation and formation of alumni, just we should all know that it's not founded by me, Pralay, or Tridip. The Alumni Association was founded long back by the person sitting idle, the rock solid Dr. Kalyani sir and his team. Way back, we were students. The first alumni meet was there, held by a very limited number of students, ex-students, which was organized by Kalyani sir, PK Mishra sir. That time Ashok Rai sir was the student, and lot of other. So far, so Pralay, we remember. Uh, Before passing on the mic to Dr. Pralay for his moderation, the usual job what Pralay used to do every CME for last two CMEs, I am doing it. It's an appeal to all the alumni who are watching and will be watching in the coming days, our 19th CME, that we are organizing and we are making up a benevolent fund to back up our alumni at the times of need. Recently, we lost two of our alumni, Dr. Mandi and Dr. Uh,
Saurav
I
Kumar.
forgot Saurav Kumar, right? So we contributed with the help of your contribution 50,000 apiece to their wives so that their family could be supported, though it had been a very small amount. But still, we request all the alumni across the globe, whoever can contribute anything above rupees 1, please contribute in the PNB account. Account number is been given in the narration, as well as the account number is being displayed while the CMEs are going on by our backstage editor Arko. So we almost are now 2000 plus alumni across the globe. We had been able to connect through USA. We had been able to connect Sri Lanka, Nepal, Bangladesh. We had connected Australia, but it's not been live on now on our CME platform. But very soon we'll be having Australia also on our CME platform. We are almost been able to connect all the states of our country from wherever we are in touch with our alumni. So it's a appeal, earnest appeal to all the alumni. Please pass on the message of the Alumni Association to whoever you are in touch, whatever batch, be it DPNH, be it BHMS, or be it MD. Please pass on the message and come and join the Alumni Association. Thank you. And over to Pralay, sir, for moderating the
Yeah.
session.
Thank you, Bidyut, for your very lively broadcast. And coming back to today's discussion, coming back to the CME of uh, NIH Alumni Association in this webinar platform. I'm privileged, in fact, and I'm privileged. I'm very thankful to Dr. Riyom Taipodia. He has been always good for the alumnus, as well as he is a very good orator. He has spoken about the necessity he felt. He has spoken about why he chose the topic to discuss in this platform today. During his post-graduation, in his dissertation, in his thesis, he had done a job. he has made a dissertation in the topic of urinary tract infection in a post-menopausal woman. And that has been well focused in this platform today. What we always desire, what we always wish. The sample size was 30, and out of 30, this 25 cases improved with homeopathic medicine. By his talk, we can understand how enthusiastic he is. By listening his speech, that the audience, whoever from wherever they are watching, will be confident enough to practice homeopathy. In his talk, he has said that why he is interested to talk about to talk about the urinary tract infection in postmenopausal women. As you all know that the common infection in women is urinary tract infection. And in postmenopausal ages, because of decline of hormone, estrogen and progesterone, there is a rapid shift of hormonal level, estrogen and progesterone in a menopausal woman. And that in fact invites the infection in the urinary tract. The most common infection in urinary tract caused by a gram-negative bacteria, which is been called as E. coli. We all understand this, and we are confident enough to practice to treat a case of urinary tract infection by using the homeopathic medicine. The only part is that the doctor has to identify the modifiable risk factor. The doctor has to identify abnormalities behind the suffering. By identifying the modifying risk factor, one can decrease the suffering, one can improve the disease condition. Here is a point to discuss right now, and I believe that it is very important to discuss in this platform because this is a postmenopausal, and in postmenopausal time, that many of postmenopausal women they suffer from they suffer from they suffer from diabetes, and that gives many more that gives many more burden into the suffering. It is true that if we identify the risk factor and if we treat the underlying cause, the symptomology will be improving without any delay. That is we understand by this time. The interesting part of discussion is that the urinary tract infection, we do have an idea, and we have studied this, that urinary tract infection will always have a burning, but it's not true. To begin with the urinary tract infection, there can be burning, but after suffering from 2 days, 3 days, 4 days, the burning sensation can disappear. And this is the alarming part. If some women have a frequency of urination, one has to undergo investigation. He will do the urine examination, routine urine examination, as well as he will ask for the culture of the urine. If the colony count found to be higher, found to be abnormal, then one has to treat accordingly. Dr. Taipodia has have given an example that if we take the case very seriously, including the mental symptom, the disease condition improves. He has treated a case of urinary tract infection by nitric acid, and you have seen the result, how improvement was possible. That is an excellent part from Dr. Taipodia as well as from the part of the homeopathy. I do not have anything to add on in this discussion today. Still, I am very excited and tempted to talk about certain medicine which comes in use of treatment of urinary tract infection. One drug is Apis mellifica. Whenever we get a urinary tract infection, we try to incorporate the medicine Apis mellifica. And you all know that Apis mellifica is very quarrelsome. So if you find a very quarrelsome woman with urinary tract infection, with a burning urination, and the hot patient, and there are many points which speaks about the features of Apis mellifica, we prescribe this Apis mellifica into that case. My point of discussion that when we are concerned with the urinary tract infection and we are likely to prescribe the Apis mellifica, the second most common drug comes in our mind, that is Lycopodium, because Lycopodium too have the similar mentality like that of your Apis mellifica. Lycopodium, Apis mellifica is quarrelsome, and Lycopodium is dictorial. And Lycopodium dictorial is very beautiful dictorial. Lycopodium quarrels with his own mates, his own people, in the family, in his known, in his very near and dear, that he quarrels with them and has a dictatorial tendency. But the Lycopodium is a chilly patient. Here is the fine difference between the prescription of Apis mellifica and the Lycopodium. And we do have plenty, endless, ceaseless drugs which speaks about the effectiveness in case of urinary tract infection, beginning from aconite, belladonna, cantharis, equisetum, sarsaparilla, terebinth, eupatorium purpureum, Chimaphila umbilicata, Staphylos agria, Maxol, Uba ursi. There are a number of drugs, but I would like to talk about one very interesting drug which are being used in case of very obstinate urinary tract infection. May it be in adolescence period, may it be in the adulthood, may it be in post-menopausal time. The medicine is the psychotic compound. This psychotic compound works in case of urinary tract infection as well as in case of obstinate tinea corporis too, with the same feature. How brilliant medicine it is, this psychotic compound is, that in case of very refractory cases of urinary tract infection, we can use this drug. The indication of psychotic compound in case of urinary tract infection, or it may be in obstinate tinea corporis, the indications are same. Psychotic compound is a drug which has much of the similarity with Thuja occidentalis. And then the characteristic point of psychotic compound to use in case of urinary tract infection as well as in obstinate tinea corporis is that the psychotic compound have the excessive sweating over the scalp. Sweating over the scalp like that of your calcarea carp, like that of your sanicula, like that of your silicea. And this feature speaks about the psychotic compound, that there is excessive sweating over the scalp. And this drug also have egg intolerance like Ferramet. This drug also have, this psychotic compound also have egg intolerance like that of your Ferramet. This drug also have a backache like that of Calicarp. This drug also have symptom like that of your Thuja occidentalis. This picture, this scenario, this symptomology that talks about the psychotic compound. And in our day-to-day practice, we have found that the urinary tract infection, which usually does not go away, in spite of modifying the risk factor, like making some habit of drinking more of the water, like using the very clean toilet, adopting all the means, still this urinary tract infection doesn't go away even by applying the most indicated medicine. If you do not get result, think of the psychotic compound And I believe that this medicine will act wonderfully. At the end, what I would like to alarm, at the end, I would like to talk about very alarming point of your uh, urinary tract infection. That is, if this urinary tract infection remains untreated for days, for weeks, for months, for years, if that person particularly have a diabetes mellitus, means urinary tract infection with diabetes mellitus or may not be with the diabetes mellitus, the person in an untreated case can can lead to urosepsis. And urosepsis is a very much critical that causes a very critical condition of the patient. Urosepsis causes multi-organ failure in within very short period of time. So with the urosepsis, if somebody develops with the urine tract infection, if somebody develops urosepsis, even then the patient is hospitalized, and by giving a number of modern medicine too, by giving a number of antibiotics too, the patient may not improve with. And if once this multi-organ failure begins with, because of the untreated urinary tract infection, patient will expire. So one has to monitor, in fact, one has to keep a good vigil while you treat a case of urinary tract infection, particularly when the patient have a comorbidities like hypertension, like diabetes mellitus. So this was, in fact, a very wonderful experience today to hear from Dr. Monoj Behra. He has spoken about uh, Eponymous sign. I'm very, and it was a wonderful description by him. And we are sitting in Kolkata, and someone is speaking from Itanagar. Dr. Riyom Traipuria talked from the Itanagar. Dr. Monoj Behra talked from Gandhinagar, Allnagar. This is a wonderful experience today. And in the early hours of this webinar today, Dr. Swapan had joined. He has given his welcome speech into this platform. He is a very renowned teacher in our institution, as well as he is a very good clinician too. He is a guide of the postgraduate students. Under his guidance, many of the students have completed their MD, and they are well placed in the country. And Dr. Swapan being a very good person too. Today we have a very wonderful seminar where Dr. Monoj Behra as well as Dr. Riyom Traipuria has taken their effort to talk about in this seminar. And I would like to thank Dr. Kalyani sir. I would like to thank Dr. Bidyut Mukherjee and of course Orko for making this webinar possible today. With these few words, thank you so much. My heartfelt thanks to all of you, to all the viewers who are watching as well as who will be watching in future. Thank you so much.
Uh, I think Dr. Kalyani sir should be there on the stage. Orko, please bring up Dr. Kalyani sir and bring me on the backstage. We'll have the Q&A session, and to conclude with the speech of Kalyani sir.
Presently, we don't have any questions. Kalyani sir, it's over to you to conclude the session, sir. With all due respect.
Many thanks to all of you, especially first to Dr. Swapan for sharing his shoulder after a long period for the purpose of the CME and Alumni Association. I am really happy and think all of us are very, very happy by voluntary and nice participation of Thapun Pal, and we expect many more support and assistance from Thapun Pal by inspiring all other alumni representatives who are working presently at NIH. Then Dr. Pralay Sharma, giving thanks to him is much less. He is much beyond thanks. Always, whenever there is any turmoil, problem, any expectation, he is always in the front line. He will come forward of his own and he will help at his level best. Special thanks to Manoj Kumar Behra for his giving beautiful speech. Many of us may consider that these signs are not that much important nowadays because CT scan, MRI, USG, all other modern investigations are available easily. But it is not true. First of things, you must agree with me that if any of us want to increase our confidence, it is the only way to gather knowledges, either by CMEs, continuous medical education, or by studying. So knowledge is power. The more you learn, the more you will realize how stronger you are becoming. So go on learning these science and other subjects, allied subjects with homeopathy. Second is, as we are increasing confidence, we also increase our field. Just I am giving one example. If a patient comes with a pain in the shoulder, as it was shown by Dr. Behra, and it was understood by any of us, any of our homeopaths, and case is immediately referred to any medical college emergency department, and there they will do everything, USG or CT scan, MRI. Ultimately, it will be detected as there is a bleeding rupture of spleen. So just imagine how much credit will be given for that homeopathic doctor like us by the allopathic surgeons and emergency department of hospital, and how much faith, love, and confidence will be gained by the patient and his party and their relatives. Within a day, the single symptom identification of a disease probability will make your field bigger and bigger. So do not ignore these things. Try to acquire as much as possible to increase your confidence, increase your knowledge, and increase field. You'll be credited like anything if we are able to assess this diagnosis in one or two symptoms or by signs. Knowing these signs, definitely it will reduce fatality in a great. If it is delayed, if we are not able to understand by seeing the signs, many of the patient is going to lose their lives for our ignorance, for our, I should say, carelessness. Maximum number of Indian population, they live in rural areas. So is it possible for them to be exposed before big hospitals where the equipments are ready, ECG, USG, CT scan, MRI? Mostly not. Majority of Indian people live in a rural area where these facilities are not available. There, this knowledge will help you immensely. You'll be able to diagnose quickly. You'll be able to advise quickly what else investigation and necessary things should be done. You'll be able to refer the cases accordingly, and you'll be able to treat as early as possible. So it's a very nice approach, new type of approach. We should not concentrate only on homeopathic subjects, but all any other assistance for recovery, assistance for our confidence, expansion of our knowledge, and to be at par with the modern medicine. It is known by the majority modern people that homeopaths are, they do not know, they only know homeopathy, organon, and this and that pharmacy. They are not knowing medicine, surgery, gynae, etc. This view we have to change, because it has been given responsibility to us, especially the NIH alumni and NIH students. They are the most brilliant persons of the homeopathic system of medicine in the world. So it is our responsibility to change the views that homeopaths are equally competent with modern medicine people to diagnose and to treat. So thank you, many thanks for this new approach to Dr. Behra. Dr. Riyom Taipodia, it was brief because he agreed that there are many things to say, but the abstract he has given is nice, very nice. Just I can remember one incident that I told you my cases of pyelonephritis from E. coli. So to save my life, to give guard to my life, one surgeon was introduced to look after my situation by Dr. Mahendra Singh, Dr. S.K. Dubey and other senior teachers of Calcutta Homeopathy Medical College when I was under treatment of Dr. P.C. Pal. He gave me only one dose of sarsaparilla. So anyway, after 7th day, on the 8th day, from the 2nd day, culture report, count of culture started reducing. On the 8th day, when report came negative, culture negative, at that time surgeon was just before my head in the student cabin and PC Pal came. After seeing the report, then he didn't talk to me anything. He just told to surgeon, his name was Dr. S. Moitra, MS from Calcutta Medical College. Ki surgeon sahib, homeopathy te bacteria more. This was his Bengali language. Hello surgeon, can homeopathy kill bacteria? Then the surgeon told S. Moitra, many of the other teachers and my friends, students are witness. Yes, sir. What I learned today, I will never forget. Now he is working in America. He has settled there. This was one incident. I will tell you that all of you, all of us has similar type of experience. All of us can cure fever. All of us can cure diarrhea. Is there any fever which is not being caused by either bacteria or virus or some other reasons? Majority of the fever causes either septicemia or bacteremia or viremia or etc. etc. So it is, we do not do the test, culture, positive and negative. Our homeopathy medicine cannot kill bacteria or virus in the laboratory. It is true. But our medicine, if it is given in a most sophisticated laboratory of the universe, that is human body, by increasing strength of its humoral and cellular antibody can kill any and every bacteria. We are confident. So friends, brothers and sisters, we must improve our knowledge. We must test, as Dr. Taipodia shown has, there's keep recordings, cure the cases, bring before us, bring before your profession, bring before the literature, journals, magazines, get confidence, pleasure, success, and it will immensely help in the progress of homeopathic medicine. So again, thank all of you for coming and joining. It's a great pleasure for all of us that after a long time, as if since a long few decades, 1976, since 1976 till date, as if all the NI students are in the same platform. We are exchanging our views, coming together, listening, seeing, participating. So please come forward to feel the pleasure of meeting each of us. Thank you very much. Many thanks to all of you.
Thank you, sir.
Especially to Orko,
Thank you, sir. Thank you.
our background director, who is directing us, managing all of us. Many thanks, Orko. May God bless you.
Thank you, sir.
Over to you.
Thank you so much, sir. Thank you so much.
Thank you,
Thank
sir.
you,
Thank
sir.
you so much, sir.
Many thanks. All of you come forward and propose the names of the speakers. That will greatly help us to organize.
Yeah, that is, sir.
Okay. All together we'll make this CME most successful in the world, homeopathic field.
Sure, sir. Sure, sir.
Thank you. Many thanks.
Now over to you, Orko.
So thank you guys for watching. I hope you have enjoyed today's CME session, and thanks to all the panel members for having me with you. And finally, it's time to say a good night. And also before that, if you are new to this channel, please go and subscribe to this channel to get this related contents. Upcoming CMEs also over here, and also do follow us on Facebook, Twitter, and Instagram. Links are on the description. And if you want e-participation certificate, which will be auto-generated after you enter your name, for that you have to give answers to 3 questions, 3 or 4 questions, after which if you get 50% or 20% right, then you will get a certificate. Just that, or that link is also given in the description, so do make sure to check everything. All the links are given in description. And also, in order to get updates on other CMEs, means other upcoming CMEs, whenever we will schedule a new CME, you may get update by clicking on the notification bell, which you will get after subscribing the channel. I means after clicking on the subscriber button, and then you will get a bell. You have to click on it, and you will get a turn on notification option. Just click on that, and from there you can get any information anytime, all the time, whenever we upload new videos or they schedule a new live stream. So with that, thank you, and thank you once again for having me, and good night to all dear viewers and to my panel members. See you until in next CME.